title of my talk is Peggy Lillis Foundation, Intro to the Conference in C. difficile Infection. A little bit about myself. I am an associate clinical professor of medicine at the Yale School of Medicine and an attending gastroenterologist at the PACT Gastroenterology Center. I spend a portion of my time in academia, a portion of my time in private practice. So I like to say I get to get the sample of best of both worlds. These are my relevant and irrelevant disclosures. None of us would be here today if C. difficile wasn't a major problem. And Christian just alluded to the fact that this is a global problem and that there's a society just on the other side of the pond that's acknowledging this major problem as well. This is data from the Centers for Disease Control and Prevention. It's the most recent published data that we have available, and we can see certain trends from the data. Essentially, in 2011, it was estimated that 476,400 people were diagnosed with C. difficile infection. Fast forward to 2017, we did better. 365,200 people were diagnosed in the United States with C. difficile. But this is a little bit deceptive because if you look at the number of positive tests for C. difficile, it was actually similar between 2011 and 2017. What happened in 2017 is that the PCR assay, an assay that has a tendency to overdiagnose C. difficile, was used more often. So there was a correction for true diagnosis of C. difficile. We'll learn more about that in the diagnosis section. But also take a look at the proportion of individuals with healthcare-associated infection versus community-associated infection. In the healthcare-associated infection, in 2011, about 2/3 accounted for this, whereas in 2017, about 50%. But when you look at the absolute numbers, community-associated infection remained the same. Healthcare-associated infection, defined as an onset of symptoms greater than 72 hours after admission to the hospital or within 90 days of discharge, that's what came down. So the proportions changed and became more like 50-50, but the absolute reduction was largely in healthcare-associated infections, and that's because healthcare systems were getting penalized by the Center for Medicare and Medicaid Services. If you ding institutions in their pocket, they focus on it. Better infection control, better antimicrobial stewardship, all topics we're going to be learning about today. Classically, who gets C. difficile? I like to think about the risk factors for C. difficile infection in 3 buckets: demographics, medication exposure, and environment. From a demographic standpoint, age over 65, female gender, any form of immune compromise, chronic kidney disease, HIV, inflammatory bowel disease, diabetes, medication exposures are a big one. Classically, C. difficile was an antibiotic-associated diarrhea, an infectious form of it, of course. What are the antimicrobials classically associated with C. difficile? Amoxicillin, ampicillin, clarithromycin, fluoroquinolones, cephalosporins, piperacillin, tazobactam. But I'm a gastroenterologist. You heard that in my introduction. So many of my patients are on proton pump inhibitors, the number 2 prescribed medication in the United States. And classically, a side effect or a risk associated with chronic PPI use is C. difficile. So what's the connection? Historically, we believed, remember, gastric acid, there to sterilize whatever we swallow. So if you reduce the gastric acid, more of the things that we swallow get through, and theoretically, we get more infections like C. difficile. And that's what we largely thought until 2016, when a very nice study by Goldenberg and colleagues was published. That study looked at a group of 20-year-olds that had no other medical problems. Put them on omeprazole, a PPI, 40 milligrams twice daily for 8 weeks, measured their microbiota pre and post that intervention. Post the intervention, there were increases in Enterococci and Streptococci, decreases in Clostridioides. Plainly stated, the microbiota was altered. There was dysbiosis and alteration of the microbiota, leading to that risk for C. difficile infection. What about the environment? The environment can absolutely play a significant role in individuals getting C. difficile and getting recurrent C. difficile. Why? Well, if people spend significant times in the hospital or a skilled nursing facility, they're surrounded by people that have all the other risk factors I just listed, and they're surrounded by people who might have active C. difficile. Infection control is incredibly important. How meticulous are we when we clean bed sheets in the hospital? What are we cleaning it with? Well, we're classically cleaning it with sodium hypochlorite and peracetic acid, trade name bleach. Globally, that's the accepted way that we cleanse bed sheets and towels and things like that in the hospital. Well, a very nice British study swabbed the bed sheets of an individual who had C. difficile pre and post cleansing. Pre-cleansing, 51 colony forming units per centimeter squared. Post-cleansing, 33 colony forming units per centimeter squared. So small nituses where C. difficile spores can in fact spread. I want to take us back to our textbook years and our learning years. And I wanted to tell you that C. difficile is a gram-positive, spore-forming, anaerobic rod. So what does that actually mean? What that means is that there's two phases of C. difficile infection, the spore phase and the vegetative phase. The vegetative phase is the phase that me as a clinician and those of us who see clinical patients think about. Why? Because this is the phase that releases two main toxins, toxin A and toxin B, most commonly associated with the diarrheal syndrome of C. difficile. The vegetative phase is susceptible to gastric acid and susceptible to alcohol-based hand sanitizers. So if it comes in contact with these things, it gets wiped out. Alternatively, the spore phase is a problem. The spore phase is resistant to gastric acid and resistant to alcohol-based hand sanitizers. In fact, the spore phase can last on dry surfaces on the order of 6 to 8 months and remain viable. I want you to look at your phone if you're streaming through your phone. I want you to look at your laptop, look at the desk, look at the walls of the room that you're sitting in. C. difficile spores are everywhere. Very high density in grocery stores, very high density in the produce section of grocery stores. These spore phases can last long periods of time. The spore phase requires a healthy, diverse microbiota to be eradicated. Very important concept that we're going to hear throughout the day. The vegetative phase, susceptible to antimicrobials. The spore phase needs a healthy, diverse microbiota. But in order to better understand all of what we're going to talk about today, we have to take our understanding to a deeper level. Don't be frightened by this slide. We're going to unpack it, we're going to understand it, and then throughout the day, we're going to contextualize it. So how do we actually get C. difficile infection? Classically, what happens is we swallow that spore phase. It's resistant to our gastric acid. It gets through our gastric acid into our small bowel, where there's a conversion called germination to the vegetative phase. The vegetative phase multiplies, divides, multiplies some more as it builds an army of sorts heading towards our colon. So the question is, what triggers that conversion to create that army? This is the slide that explains that, at least mostly explains that. Bile salts are what trigger that conversion. Historically, we understand that in the liver, cholesterol is synthesized into two primary bile acids, cholate and chenodeoxycholate. The primary bile acids promote germination. They promote recurrence. They promote onset of C. difficile. Whereas the secondary bile acids inhibit the vegetative phase. Primary bile acids are converted to secondary bile acids in the intestine by an enzyme called 7-dehydroxylase released by a bacteria, C. syndens. Shouldn't be a surprise that in patients that get C. difficile, there's less C. syndens, there's more primary bile acids, more likely to recur, more likely to have an onset of symptoms. Once that vegetative phase gets active, TCDA and TCDB that you see on this slide, those are the toxins. They act on the level of the surface of the colonocyte, stimulating weakening of the tight junctions, stimulating cytokine inflammatory reactions in the subepithelial space. How does that manifest? In the secretory diarrhea that we see with C. difficile, the abdominal pain, the nausea, the fevers, and the sweats. One of the biggest challenges associated with C. difficile is, in fact, recurrence. It is estimated that up to 35% of people who receive an appropriate treatment initially will recur. And of those that recur, up to 45% will go on to recur after that, and up to 60% thereafter, as patients get caught in this vicious cycle, a cycle that it is our mission to break. And we're going to learn about ways that we can break it. I'm going to give you a quick snapshot on diagnosis, because diagnosis is in fact a problem. There's a couple of approaches that we have for diagnosis. Toxin detection is the only way that we detect true infection, because we don't care if the bacteria is in somebody's system. We care that it's in their system and releasing toxin. The problem with the EIA for toxin detection is that it's unacceptably low sensitivity. So if it's positive, you can say the person has it, but if it's negative, you can't say they don't. So we have to couple it with other tests. And those other tests are the GDH and the PCR, two assays that look for the organism, not necessarily whether the organism is releasing toxin, not necessarily whether the organism is producing the symptoms. So we have to learn how to contextualize these things. And Dr. Krishna Rao later will be walking us through all of this information. At the end of the day, treatment is essential, and we have to contextualize the treatment with the pathophysiology that I've introduced. On the left, we see the germination going from spore phase to the vegetative phase. Antimicrobials such as fidaxomicin and vancomycin, they control that vegetative phase. They are effective at controlling that vegetative phase. This is why patients feel well when they're on vancomycin and fidaxomicin. The Achilles heel here, though, is that recurrence, that spore phase reconverting back. So we have several things that we can use to potentially prevent that recurrence, so-called add-on therapies. Things like bezlotuximab, things like microbiota restoration therapy, a better way of saying fecal microbiota transplantation. Now, with that being said, I've done my introduction. Let's now shift over and talk about who's speaking next and have an exciting conference day.